got a lot to get through. I think most of our presenters are online. What I'm going to suggest is that we don't take questions in between, so that we don't then get squeezed too much at the end of the meeting. And hopefully, if we've got a bit of time, we'll take questions at the end. I hope that's all right with everyone. So I think with no further ado, Hayley, I noticed you're online. So can I hand over to you for our first report out, please?
Yeah, absolutely. Thank you, Paul. Hi, everybody. So my name's Hayley, and I'd like to share with you today my LIM project, in which we changed from team-based nursing to acuity-based nursing. Next slide, please. So J89 is a 20-bedded all single side room ward. We're the only ward that performs bone marrow transplants, and at the time of the project, we currently introduced CAR T-cell transplants. These patients can become acutely unwell very quickly, in which they need urgent treatment and quite often will have a stay in the intensive care unit within their admission. When taking a team of patients, you could have multiple sick patients depending on how many transplant patients versus general haematology patients you had in your team that day. Next slide, please. At the time, the morale was pretty low, and some staff were feeling that each shift was leaving them feeling really burnt out and would impact on their days off. We tried a couple of different ways of working previously based on staff feedback and suggestions, but I have to say neither worked any better than the team base we had been working with at the time. Next slide, please.
Oh, I think you've just gone on to mute by accident, Samo.
Sorry.
There we go. Do you want to start that slide again? I think it was just
Yeah,
because
sure.
we changed slides. Yeah.
So attending LIM training provoked so many ideas on what change I could make. I went away thinking what are other areas doing that maybe I could adapt, and thought about my previous experiences. One being working on the neonatal intensive care unit. And this is when I came across acuity-based nursing. So I started looking at the evidence behind this. Next slide, please. The next step for me was, how do I even start this? I have to say I was a little apprehensive to change. Part of the LIM was to complete a process flow chart. This actually became a vital part of change. And from this, I introduced acuity-based nursing on J89 in December 23. We were already completing the SNCT data for each patient, so this gave a great start to the acuity assessment of our patients, which enabled us to start looking at the number of nurses to acuity ratio. Next slide, please. So this is just a quick slide, just a slide for guidance that we use when allocating patients to staff. Looking at the numbers, it does not mean that one nurse can only have level 0 or level 1A patients, as we know that would not be feasible. But it gave us guidance on the maximum acuity one nurse could be looking after that shift, such as I could be looking after one 1A patient and 4 1Bs. Next slide, please. So here is some of the data we were interested to collect to help feedback to staff and to provide assurance. Our metrics had increased roughly by 3%. We see high numbers of HAIs in haematology due to the treatments we give and how immunocompromised our patients are. Plus, our patients tend to have multiple devices such as Hickman lines and PICC lines. Staff retention was a big one for me, as I wanted staff to feel valued, empowered and skilled. And in August 23, I had 6 RM vacancies, and by August 24, I had 1 RM vacancy. And still today, we have no RM vacancies on 89. Next slide, please. So we were also part of a CDI outbreak at the time, but I'm so pleased to say we achieved 7 months without a CDI, which was a real achievement for us, because we were seeing 1 or more CDIs a month. Next slide, please. So I received some feedback from our consultant microbiologist, Jessica Martin, who we worked really closely with, and she fed back that there had been a stark improvement from CDI, C. diff, to those who are nurses on the call, point of view. And it's very noticeable how few patients had run into bacterial infections, and antibiotic usage had also lowered. The strengths we found of going to acuity-based nursing are that it measures both workload and patient acuity. The weakness we found so far is the varying professional judgments on scoring patients against SNCT, so further training and guidance was given to staff in acuity assessing patients, and this will continue. Next slide, please. So throughout my career so far, I've seen many projects that I've started and not sustained. So this was something I was really passionate to do this time to sustain it. Especially with the data that evidence we were providing more harm-free care than ever, and staff morale was improving. I asked a staff nurse who had just started taking charge on shifts for some feedback, and she said that she was finding that she was really enjoying the Acuity-based nursing teams and felt that it worked well. She said it helps with her knowing who needs the most support, but also gives her the opportunity to support those who need it the most. Next slide, please. So no surprise to say, the project was a bigger change than I first anticipated, and to sustain it, we needed to make this a standard way of working for J89, and we did an SOP through that. So at the beginning, there was a culture from some staff to resort back to team-based. However, as they started to see the benefits of Acuity-based and plenty of challenge, reassurance and encouragement has over time changed their mindset. And another barrier we came up against was making it work in a way that staff felt like they did not have patients dotted across the ward. This was just careful consideration, and what we did is we started allocating patients at each handover, which helped with grouping those patients together. And then the other barrier I faced was that this was a new way of working in our CSU. Nowhere else was doing it in our ward areas. So to protect the staff and patients, I needed to help the staff articulate what support we needed or could offer to others. And I was really lucky that my head of nursing was really pro for this and from that I started providing presentations to the matrons at our perfect ward, and mainly to the nurse practitioners who were the ones who were making these staff moves out of hours. And that's it from me. Thank you. Thank you for listening.
Oh, that's fabulous, Hayley. Thank you. As I said, I'm going to move us on, but I'm sure people have some questions because there was a lot going on in that. Thank you. So, Lee, are you here?
I am, yes, Paul. I'm
Super.
just here. So thank you. I'm just going to do a quick introduction, a bit of background about the Business Managers course. So my name's Lee Hawkins. I'm General Manager for Corporate Ops, and I've been the programme lead for the Business Managers course here at Leeds Teaching Hospital that ran over the past year. Our team commitment last year was to be in the top 25% of performing trusts for staff retention, and we had a recognised gap in the training and development of our business manager team, not just at LTHT, but nationally. In total, there were only 5 courses running in the UK across trusts, and none of them were formalised. So we designed this course to support our own business managers be successful in their roles, to support us with that ethos of growing our own within our trust. Key outcome of this course is to agree a LIM project within the CSU, which has been linked to one of those 7 commitments of their choice based on the training they've had, and then work with clinical teams to deliver it. So today sees the first set of presentations to come out of the programme, and I'm really excited that Kirsty Haig is here and Luke will be kicking that off. So I'll hand over to them. Thank you.
Thanks, Lee. So I'm Kirsty Haig. I'm the business manager for emergency general surgery and for pancreatic services here within AMS. My project was to provide accurate reporting about patient appointments with procedures within our ambulatory surgical centre. Next slide, please. So we'd noticed that we had a massive increase in appointments of patients who were attending our ambulatory surgical centre for follow-ups. And although AMS was doing a project around counting and coding, felt that this was probably one of the areas that EGS should really focus on. So after doing some digging into those attendances and checking patient records, we realised there were a lot of patients that were attending post-operatively, so whether that for wound reviews, having the dressings changed, some patients were coming to have the staples and sutures sorted out, or even removals of drains. And comparing that to our budget report, there was an increased expenditure on these consumables to allow us to see those patients and on dressings. So, for example, we ended up with a overspend of £948 just on those areas alone. So our focus was to see what we were able to do, whether we were able to recoup some of that money, and that would help us to deliver the financial plan and use our digital systems that we already did, because we did some counting and coding already for other procedures within that service, whether we could do something that would enable us to sort of recoup some money and see an increase in our activity levels, I suppose. Next slide, please. So some of the actions that we took to address this, like I said, AMS was already doing a bit of a project around counting and coding, and I think Kate, who I think is on the call, was leading on that. So I had quite a lot of support from her to support this project. Also had some support from the coding team, and I just wanted, from Lee's introduction from the business managers training project, we did have a session with Rob Edwards from the counting and coding team, which was really helpful, enabling us to be able to identify if there were anything that we were currently doing that should be being coded, how that worked, the whole stream of the process of putting it on, how that then converted to income. So some of the specifics that I've mentioned were around the dressings and the drain removals, and I've just included how much those appointments would be if they were coded correctly for a follow-up appointment. So for example, patient coming in for a follow-up appointment to have their drain removed, that would correlate to £320. In order to get people on board with the project, I had to think about what data capture, what metrics would be useful to show that the project that I was putting in place was working, and also for target audience. So the people that would be involved in this would be consultants, nurses, ward clerks. What would they want to see that would make this project worthwhile in terms of numbers? So a lot of the data capture was around what activity we could see, which was a change, and income generation. So our ERF funding reports were the ones that I sort of looked at. Figuring out who actually needed to be involved. So one of the LIM resources was a racing matrix, which you can see on the screen there, identifying who would be responsible, who needed to be informed. I was aware that the people that would be conducting this work are ward clerks and ultimately don't fall under my direct line management. They're managed by the nursing staff and the matrons on the ward. So needing them to be involved and get them on board. It's not a very good picture because you can't really see what I've written, but a current state versus future state. So what were we doing? As you can see, the top in purple, we weren't doing a great deal, and what that would look like, you can see there's extra steps put in there, who would be responsible, who needed to do what, and what impact that would have on the team. So in our ambulatory surgical centre, we have one ward clerk, and sometimes when that person's here, that work doesn't get done. So how would we be able to make sure that we had appropriate resources? Would this create additional work for that person? And would they be happy to do this? Next slide, please. As you can see here from the graphs, by implementing this project, we had a massive increase in our coding that was captured by the ward clerk. We had an increase in activity that was recorded. We had an increase in income generation that was clearly evident on our ERF reports. And we also had further support from our clinical colleagues. So by implementing this quite small project, the consultants and nursing staff were really engaged and wanted to know, what else could we do? Is there anything else that we're not looking at? So everything that they did in that clinic then got scrutinised within an inch of its life to see if there were anything else that we were doing that should be coded appropriately. So as you can see from the graph, the top one, the blue line, is where we were at baseline. So most months we were averaging at most 30 outpatient appointments with procedures. Massively increased, and the red arrow is where we formally implemented the process, and the money, which is the red line, follows pretty much similar in terms of the activity. One thing that I've not included on here is the first month that we did it was November. In October, we recorded 173 as total follow-up and new. But in November, we actually generated 384 appointments, and for follow-ups only, which is where this kind of graph looks at, in October we generated £5,800 of income, but in November, after implementing this, we actually generated £38,000 of income for the service, which was absolutely massive. And then the bottom graph is our activity plan, which was for 24-25. So EGS did some outpatients with procedures, so you can see the black line was our target, but you can see clearly there we have massively gone above and beyond the trajectory of us being able to record those appointments. So absolute massive well done to everyone that was involved in this, because it really shows through, including all of the reporting that we've done. Next slide, please. So what went well in regards to this project? So it was a small change to our current processes, but it was a large gain. Patient experience. Now, this is something that I've got on the other slide as well, for something that we could have done a little bit better. But we'd have patients contacting either our EGS admin team in outpatients, or even the ambulatory surgical centre themselves, saying, we really can't get into the district nurses, we can't get in touch with our GP, what should we do? You've told us that our dressing needs to be changed. So instead of those patients worrying that something could go wrong or that they might end up with an infection, we were able to just bring them straight in to the service and get them sorted out and get the treatment that they needed quite quickly. Our nursing colleagues were massively engaged. Our matron and our senior sister of those services really engaged and on board, and the nurses who would carry out these procedures on the patients. Every time I went in, they were like, oh, how are we doing this month for numbers? You know, it really geared everybody up to just add another level to what they were doing. Our consultant colleagues massively engaged. So we have a consultant meeting on a monthly basis. And when I fed back the October versus November numbers, they all nearly fell off the chairs. But again, it spurred them on to do better. What else can we do? So that was really positive. There was a massive improvement in our communication with the clinicians to the ward clerks, which in turn improved our documentation. So everything that we do with patients is documented on PPM. Whereas before, if someone just nipped in for their wound to be done, that necessarily sometimes would not be captured. So again, massively improved accurate data capture. Next slide, please. So what would I have done differently? I think involvement with our ward clerk at this being an initial idea stage would have been really helpful, because I kind of included her at the, oh, we're going to be doing this stage, and she was like, oh, I would have liked to have been involved, and some of her feedback and how that would have impacted her would have been really helpful right at the start of the process. I would have liked to have audited the patient experience specifically for these patients. So we do get really positive feedback about the service as a whole when people do the feedback forms. But I didn't really collect anything that was specific to these patients that are coming in for this specific type of treatment. I would have created my SOP documents a little bit earlier. So unfortunately, the first part of what we were doing was winging it a little bit, because it was something that we'd done previously with some other abscess pathways. But I think having a robust SOP document a little bit earlier than we did have would have led to everybody knowing the whole process a lot quicker. Wider staff pool training. We have now got other people within the service that understand how to do the coding, how to admit, discharge and cash up the clinic. So that has now been resolved, but at the time of this project being implemented, there was only the one ward clerk and our EGS admin team that knew what to do. So moving on and taking this forward, we're going to continue doing this, because although we don't know what the financial position's going to be for the next year and it's all still a little bit up in the air, this is best practice. We should be doing this as our bread and butter day in, day out. So we're just going to continue that. We have rolled out other coding processes. So one of our pathways that was embedded as accounting and coding for abscesses, actually we recognised by doing these counting and coding projects that they should have been documented as day case procedures and not as an outpatient. So we're implementing that. And as I said at the beginning, I don't just business manage for EGS, I also manage the pancreatic services, and we've rolled out into that service as well. well, the counting and coding for outpatients with procedures, and they are above their trajectory too. So it's helped both my services by doing this project. Thank you.
Thanks, Kirsty. That was great. There's a lot going on. I really like your reflections as well about how you'd have, you've got a successful project, but how you might go about doing it next time. That's really brilliant.
Thanks, Paul.
Luke.
Hi, good afternoon, everyone. My name's Luke Wilby from the Oncology CSU. So my project aim statement was to go back to basics within the haemophilia service to reduce DNA appointments, implement and utilise our current digital resources to create a more accessible service to patients. So next slide, please. So what were our problems and challenges? So the rocks in our shoes. So it was quite evident that we had some clinician buy-in. So this is quite a big challenge for us to get the clinicians to buy into that change. And then also the time that we had to spend on making this change with the clinicians. We also had some quite ingrained processes. So that's within the clinician team, but also the admin team. So quite a barrier into making any changes that we had. And also these patients that are within the haemophilia service have lifelong conditions. So I knew straight away, and the team knew straight away, that the clinicians would not budge in to discharge these patients if they had so many DNAs back to the GP, etc. So we needed to really think different on how we managed these patients and how we supported these patients, but also how did we make these changes. So the start of our journey, as you can see from the graph, our DNA results for the haemophilia service were quite high. I think in June they were at 15.5%. So for that period of time, they were quite high. So we knew that we needed to make some changes. And what were our aims? So looking at the 7 commitments, so we wanted to obviously increase our efficiency within our outpatient department. Obviously, we had a lot of wasted appointments with our DNA rates being that high. And we wanted to look at the resources, so look at what we already had within LTHT to digitalise this service. And what could we do to move it forward? And by doing that, obviously make us a little bit more sustainable in that process. So next slide, please. So what actions did we take and our next step? So we went back to basics with our admin processes. So a reminder that we need to give our patients that reminder that they did have appointment and sort of make sure that they were aware of appointments, giving that patient choice, etc. We rolled out Patient Hub across all our haemophilia clinics, which was really helpful. And then we implemented patient-initiated follow-up for mild bleeding disorders, which were our highest DNAs patients. So we have a 3-year PIFU pathway. What tools did we use? So we used a PDSA cycle to really ensure that we were planning what we needed to do. We were acting on our results. We were studying them, and then we were really doing that. A little bit of a spoiler alert, we are at the planning stage because we haven't been able to sustain our results, but that's okay. We're not going to dwell on that. We're just going to keep pushing forward. And then staff engagement. So we had regular engagement meetings with key stakeholders. So our patient service coordinator, data manager, haemophilia clerks, our consultant and our CNS workforce to really embed these changes and make sure this process sort of really took off. Next slide, please. So what were our outcomes? So following these actions, the haemophilia service DNA rates went from at the highest 15.5%, which I have said, to a lowest DNA rate of 6%, which is quite an achievement, quite a reduction. We managed to pull together a PIFU clinical scoping document to see which patients were eligible for PIFU and who was clinically suitable for PIFU. And the pathway is now being utilised, and Patient Hub is fully rolled out into the haemophilia clinics. So as you can see just below, on the left-hand side, that's where we were for our DNA rates, and on the right-hand side, that's where we are/were, because we've gone back up again now. So like I said, 6% was our lowest DNA rate. Next slide, please. So what went well? So staff engagement. So the engagement from key stakeholders. So seeing that change, increase that engagement. So the patient service coordinator sort of saw that improvement of DNA results and wanted to do more. What had a look at what could we do, etc. Patient hub, so support from Rob Charles to ease consultant worries, to ease our patient service coordinator worries. And we took a really slow and steady process for patient hub. So instead of just rolling it out across our haemophilia service and our waiting list, we really took it slow and steady to see what change we could do and to make sure that we didn't rush that process. So PIFU pathway, as you can see from the right-hand side slide, is now increasing. So we've got 33 patients on PIFU. It is a slow process, but it's a process that is starting to increase now, which is great to see. Celebration of success. So we did this during our excess meetings, during our service review meetings, and really had that tri-team support when we started seeing the decrease in our DNA results, which is really great to see. Next slide, please. So what would we do differently? So probably start the DNA reduction process with the implementation of PIFU to try and get some quicker results and greater efficiency turnout and better for patient care. So our PIFU process has been extremely slow. So probably started with that to make sure that got up and running that little bit quicker. So what are our next steps? So continue to increase those PIFU numbers where clinically suitable, continue to work with organisational development. So I forgot to mention, we are now, I did mention briefly that we're at the planning stage of our PDSA cycle. So we're working with organisational development as a team to see what improvements we can make with our team working, and then what service improvements that we can make. So we want to continue with that work to drive our service forward and further develop our team. So review the whole haemophilia service by doing that to identify further improvements that we can make, and then reduce, sustain and maintain our DNA results. So if you look at the chart to the right hand side, our DNA results have gone back up again. So we need to really understand, as I said, we're at the beginning of our PDSA cycle. So what can we do now to make sure we are maintaining and we are sustaining those DNA results? So what was our key learning? So change doesn't happen overnight, and it's okay to revisit those changes if they're not working, or if we need to make changes to maintain and sustain that improvement. And a team that want to implement change will make change. So as I mentioned right at the beginning, it was quite a big worry to get the buy-in from clinicians mainly. But when they started seeing that change was working, it was clear that they did want to make that change. So when you get people wanting to make that change, it really benefits change. And that's all from me. Thank you very much for listening.
Thank you. Look, there's some really interesting data in there, and it's helpful, isn't it? If you've got the data, you can have the discussion. If you're just going off anecdotes, it's all much harder. So I think we've got a whole about 90 seconds left of our session. Would anyone like to ask any questions of any of our presenters? Someone's put their hand up. I can't. Andrea.
Oh, hi, Paul. It's Andrea Bennell from Oncology, Deputy General Manager. Just in particular, I want to say thank you to both Hayley and Luke from Oncology for reporting out today on both of their projects. Really, really interesting, both of them, and obviously for Hayley's, I think sustainability is a key here. Retention is all important at the minute, so that's fantastic. I feel like I'm holding hands with Luke on DNA rates and PIFU, to be honest. That I know that has been a slow start. It's been hard to get off the ground for all the reasons that Luke's just explained, but he's really committed his efforts to trying to improve this. So just thank you to them both.
Thanks, Andrea. Yeah, well, thank you to all the presenters today. And Luke, I know you say it's kind of come back a bit. That's not a problem. You know, these aren't failures. This is, we've tried something, we'll plan, we'll go through the process again. We've got a bit more data. We'll be able to make a slightly different intervention next time. I thought what was stark was that how quickly you got some of those numbers to change. It was kind of June to July, went from 16 to 8 or something, which is So you can make big changes.
Yeah.
Like you say, it's hanging on to them, isn't it? But no, fantastic from everyone. Thank you for joining us today. For the rest of you, I hope you found that as interesting as I did. I hope you get a chance to get out over the long weekend, enjoy the sun, and see you all next week. Take care, everyone.
Thank you. Bye-bye.
Bye.